this sort of assay just kind of showed up one day, and was open-minded, in the way that I think robotics and laser surgery has helped us manage as surgeons this disease. I'm going to present one of these first cases that I saw that really kind of actually interested me, because it seemed to be an accurate representation of the rather large-scale disease that this gentleman from the San Joaquin Valley in California presented with. So this is a gentleman who walks into my clinic, and he's 63. He is pretty much an active smoker. He quit, yesterday. And it's one of those things where I was able to get him in, and of course the referring person was like, "Hey, seems really exophytic. Maybe you could do the robot on him." And I'm like, I don't know if this projects really well, but this is a massive tonsil cancer. I mean, it's at least a T3, moves, it's really big, some nodes here as well. And obviously, he's not a great candidate for surgery. I decided that, chemo-RT really kind of made the most sense. So we staged him as T3 and 1. And he went on to have concurrent chemoradiation with two 100 milligram per ml squared boluses with our partners in Turlock. And he came back to see me about 2 to 3 months later. I hadn't really seen him. He lives close by to this outside facility. But he comes back because there's a PET scan at 3 months that's hot and positive, saying, "Oh, well, maybe you actually need to do an operation after all." I see him. I take a look at the PET scan, but, it's an outside scan, so I can't really see it that day. I examine him. It's an amazing response. Like, there's this very large tumor, and I was, wow, I need to see this guy back because salvage may be necessary. But there's definitely this little ulceration sort of where the anterior tonsillar pillars inserting in the tongue base, so the front part of the tumor, and I can't tell if it's mucositis or a burn from his treatment or whatever, but it looks inflammatory rather than neoplastic, but I don't really know kind of what to do next. And, this is a gentleman who did not have insurance, but we were able to get him into a program that we have, and I was able to order his NavDx. It was $27,000. Which was to me, that seemed really high. And I've been using this for a couple years now. It's certainly the highest I've seen. And I thought, oh, well, gosh, I wonder, even though if his baseline imaging was negative for distant disease, that, there's a big tumor, but there's probably micromets. Who knows what's happening with him.
Chris, was that drawn before before chemoradiation or after chemoradiation?
Thank you for clarifying. That was pre-treatment. So when he came in, I was able to get this done at Stanford before he went to our outside facility.
And maybe just an important point,
Yeah.
A lot of people ask, does the level of value correlate with disease burden? At this moment, that's not a clear association. What I would argue is that an individual patient's trend over time is more important than comparing a value between patients. You can't be comfortable with someone's value at 60 or someone's value at 27,000 about where the disease is and the burden of disease. And some of that has to do, if you think biologically, about the shed factor, the apoptosis, and how we intrinsically biologically deal with things. So be careful. It's not about quantitation, and some of our work, Eleni Rettig and others have looked at this. We know higher levels predict nodal involvement at baseline, but we don't know that higher levels mean distant disease, or when someone has metastatic disease, what that means, and we'll show you that. So
Yeah.
important.
And so he went all the way to zero, essentially at 3 months. And so I had seen Eleni's paper, and I thought, well, wow, this is a really big primary, but pretty average volume neck disease. This was a really clinically useful scenario for me to have this biomarker, because, I was a lot more comfortable. I'm still seeing him clinically, but, in the setting of a positive PET scan and this negative test, which is still, something that I'm taking into account as a possible clinical value, right? I mean, we need to evaluate this as a community of head and neck oncologists. It actually put my mind at ease, and certainly that of the patient and family.